Hi friends, this is Dr. Father Baker again, and this time I will be providing you with an overview of the paranasal sinuses and the anterior skull base. The paranasal sinuses can simply be referred to as air-containing spaces within the facial skeleton. And while this is true, it is also true that this particular region of the paranasal sinuses is notoriously affected by anatomical variants. And it is important that we recognize these anatomical variants because they can have significant clinical relevance, especially when evaluating patients with sinusitis. So what I would like to do here is provide you with a few such normal variant cases. You need to identify them and understand their clinical relevance. Here is case 1, case 2, case 3, case 4, and case 5. And while you might have identified some of the anatomical variants, what I would like to do is go into the details of these anatomical variants as to how and why they occur and give you the importance as to why we need to identify them in terms of their clinical relevance. But before we go into the anatomical details, it is important that we try and understand why they occur, which can be done by answering a basic question, which is, what is the function of the paranasal sinuses? While numerous functions have been proposed, the top two include to support the brain and to make the facial skeleton lighter. And to understand these two basic biological roles, we will have to look into the evolution of the paranasal sinuses. One of the many features that distinguishes us from the apes is a well-developed frontal lobe, which meant that it required some support inferiorly, which could have been possible with a thick bony bar, but that could have made the facial skeleton heavier and would not have allowed us to keep an upright posture, and hence developed the paranasal sinuses, especially the ethmoid sinuses, uniquely well formed in us humans. They not only provide support but do not add any weight at all. This type of labyrinthine structure is present all around us. Look at the room itself that you're sitting in. A lot of open space and then the walls, which is similar to the architecture exhibited by the paranasal sinuses. Some other unique features to the paranasal sinuses: no two sides are similar and they are unique to each individual, as are our fingerprints. So you could very well have your own paranasal print as well. So with that brief glimpse into the evolution of the paranasal sinuses, which I find is absolutely fascinating, let us understand the embryology, which will help us evaluate the anatomy better. It all begins with the condensation of the mesenchyme along the nasofrontal process, resulting in the formation of the precartilaginous nasal capsule, which demonstrates a median mass, which will become the progenitor of the nasal septum, and the lateral masses, which will form the turbinates, the sinuses, and the nasal alar cartilages. With further mesenchymal differentiation along the lateral nasal process, there are 6 major furrows with their corresponding ridges which develop, called the ethmoturbinates, of which the maxilloturbinal is the largest. Each of these can be divided into an anterior ascending and a posterior descending, or a more horizontal portion. Not all of these, however, persist. Of these, the maxilloturbinal goes to form the inferior turbinate, the second goes to form the middle turbinate, the third the superior turbinate, and fourth and fifth, if purses, go to form the supreme turbinate. That is regarding the ridges. What about the furrows? The first furrow is present between the first and the second ethmoturbinals. The descending portion forms the infundibulum, hiatus semilinearis, and the middle meatus. And outpouching from the ethmoid infundibulum results in the development of the maxillary sinus as well as the frontal and anterior ethmoid sinuses. The ascending process continues to the formation of or contributes to the formation of the frontal recess region and results in the development of some frontal and anterior ethmoid sinuses. Again, notice that the frontal and some anterior ethmoid sinuses have some embryological variation in terms of where they develop from and therefore the underlying anatomical variants that we see. The second furrow lies between the second and the third ethmoturbinal and contributes to the superior meatus. The third furrow lies between the third and fourth ethmoturbinal and corresponds to the supreme meatus. The posterior ethmoid sinuses develop from the superior and supreme nasal meati or meatuses, and therefore the underlying anatomical variation as to depending on where they develop from. These posterior ethmoid sinuses are notorious to extend into the adjacent maxillary and sphenoid sinuses, which we will discuss later. So we spoke about the lateral nasal wall. Let us look at the nasal septum. The nasal septum consists largely of the vomer, the perpendicular plate of the ethmoid bone, the quadrangular or the septal cartilage, the membranous septum, and the columella, with minor but important contributions from the nasal crest of the maxillary bone and the palatine bones inferiorly. This nasal septum is never in the midline. And why is that so? It is thought that the nasal septum is a relatively fixed structure between the floor of the anterior cranial fossa above and the hard palate below. And therefore, as the frontal lobe grows and pushes on the anterior skull base, there is secondary deviation of the nasal septum that results. When we consider the nasal septum, it is important when we distinguish the cartilaginous nasal septum from the bony nasal septum. And why is that so? The cartilaginous nasal septum defines the internal nasal valve. It is that particular region that is demarcated medially by the cartilaginous nasal septum and laterally by the alar cartilages at a level just anterior to the inferior turbinates. If there is significant narrowing on one particular side, like seen here, it will result in significant turbulence of flow of air, mimicking symptoms of sinusitis without any inflammation of the sinuses themselves, and such patients will develop from septoplasty, and therefore it is important that you look at the internal nasal valve or the cartilaginous nasal septum in the coronal plane just anterior to the inferior turbinates. This was case 1 that I had showed. What about the bony nasal septum? It often is deviated to one particular side, that is okay. It becomes significant when it abuts one of the turbinates or in fact goes and abuts the lateral nasal wall. The lateral nasal cavity Well, it demonstrates the turbinates, and like seen here, typically when you see a case of paranasal sinuses, you will notice that one half of the turbinates on one side will be more prominent than the other. Please do not call this abnormal. This is basically the nasal cycle, and it switches back and forth. I think it can be considered to be abnormal when one of the turbinates actually touches the nasal septum, and that can be considered as some hypertrophy of that particular turbinate. Of the turbinates that we see, the inferior turbinate is the largest. It attaches anteriorly to the conchal crest of the maxilla and posteriorly to the conchal crest of the palatine bone. It has a thin maxillary process that attaches to the inferior rim of the maxillary hiatus. It should be remembered that the nasolacrimal duct terminates at this particular site in the anterior superior portion of the inferior meatus. Clinical significance? Well, whenever the surgeon does an inferior turbinectomy, he does not do a complete inferior turbinectomy, because if he were to do that, then as the nasolacrimal duct opens there could be scarring that could be formed, resulting in blockage of the tearing and therefore epiphora. Therefore, whenever an inferior turbinectomy is performed, it is a partial inferior turbinectomy that is done. The middle turbinate attaches anteriorly to the lateral margin of the cribriform plate. Progressing posteriorly, it migrates down the lateral wall to penetrate through the ethmoid labyrinth to attach to the lamina papyracea. Further posteriorly, it attaches to the medial wall of the maxillary sinus. This three-dimensional orientation, initially sagittal, then coronal, and then axial, gives the middle turbinate exceptional stability. Again, whenever a middle turbinectomy is performed, it's only a partial middle turbinectomy that is performed because the surgeon does not want to pull upon or do a complete turbinectomy, because he could cause an iatrogenic fracture at the anterior skull base, resulting in CSF rhinorrhea. One thing to note is that as the middle turbinate attaches to the lamina papyracea, the medial wall of the orbit, it sweeps across the bony, the ethmoid labyrinth. This attachment that goes to the lamina papyracea is known as the basal lamina, and it divides the ethmoid sinuses into a larger group of anterior ethmoid sinuses and very few posterior ethmoid sinuses. Certain variants of the middle turbinate, well, you must have identified this. There is pneumatization of the middle turbinate. It can be unilateral or sometimes bilateral. It encroaches upon the ostiomeatal unit complex, and that can cause obstruction to the secretions, resulting in sinusitis. Occasionally, you can see a mucocele develop within the concha bullosa itself. This was your case 2. And why am I showing this separately? Well, there is pneumatization of the middle turbinate that is seen, but notice that this pneumatization does not extend into the middle turbinate, and this is a paradoxical middle turbinate because it occurs medially. This pneumatization, note, does not extend into the turbinate itself. It stays within the vertical attachment. This should not be called a concha bullosa. This is known as the interlamellar cell of Grunwald. Significance: this rarely causes any encroachment on the ostiomeatal unit complex. The superior turbinate attaches to the floor of the anterior cranial fossa. Well, the significance lies that it is the lateral margin of the olfactory recess, which is bounded medially by the nasal septum. Any pneumatization of the superior turbinate can encroach upon the olfactory recess. Moving on to the drainage pathways, here we see a patient with sinusitis and notice that there is an iatrogenic defect made along the floor of the maxillary sinus, a procedure that was called as Caldwell-Luck procedure and was thought that it could help patients with sinusitis. But it never relieved them of their symptoms, and this was puzzling until we understood the important ciliary action which helps drain the sinuses. Typically, the cilia push the secretions towards the natural opening of that particular sinus, and therefore even if there was a defect that was made along the floor, it never really worked because the secretions were continued to push to the natural opening, and therefore our understanding about the secretion drainage increased, and that resulted in our adopting FES or functional endoscopic sinus surgery procedure, which basically opens up the region where the sinuses normally drain, and that results in significant relief of symptoms of sinusitis for the patients. So let us go into the region of the ostiomeatal unit. Well, it is not a single anatomical structure, but is a composite of multiple structures that are present in this region. So what constitutes the ostiomeatal unit? Well, it is the maxillary sinus ostium, the infundibulum, which is bordered superiorly by the Ethmoid Bulla and the anterior ethmoid sinuses, inferiorly and medially by the Uncinate Process. The infundibulum leads to the hiatus semilunaris, which goes into the middle meatus. Notice that there are numerous surrounding structures that can influence this drainage pathway, including the middle turbinate, the Ethmoid Bulla, and the Uncinate Process. The Uncinate Process is actually a crescent-shaped bone. Anteriorly and inferiorly is attached to the inferior turbinate, marks the nasolacrimal duct. Posteriorly, it has a free margin which marks the hiatus semilunaris, which can get pneumatized and encroach upon the hiatus semilunaris or the ostiomeatal unit complex. Superiorly, the attachment of the uncinate process is variable. Thus, it can attach to the lamina papyracea, in which case the infundibulum is closed superiorly, a pouch termed recessus terminalis. If, however, the uncinate process attaches to the skull base of the middle turbinate, the frontal sinus now opens into the infundibulum. The ethmoid infundibulum is that structure which is bounded superiorly by the ethmoid bulla and for a small portion anteriorly by the anterior ethmoid air cells. The mesial surface is the lateral surface of the uncinate process, the height of which depends on determines the depth of the infundibulum. Laterally is the lamina papyracea. The maxillary sinus ostium. The maxillary sinus drains via its ostium through the infundibulum into the hiatus semilunaris and the middle meatus. Anatomical variants: the presence of infraorbital ethmoid cell, the Haller cell, can narrow the infundibulum and therefore encroach upon the ostiomeatal unit. The maxillary sinus, during its early development, lies medial to the orbit. It then continues to develop into the body of the maxilla until about 20 years of age. Cessation of growth occurs after the third molar tooth erupts. Some important variants: you can have the hypoplastic maxillary sinus to be distinguished from the silent sinus syndrome. Important to notice that in the setting of either of these anatomic variants, which are the hypoplastic maxillary sinus or the silent sinus syndrome, the uncinate process is extremely close to the inferior wall of the orbit. And if an uncinectomy is considered, then the surgeon could cause an iatrogenic fracture of the inferior wall of the orbit. And therefore, when you notice this sort of anatomical variant, please mention the close association of the uncinate process to the inferior wall of the orbit, so the surgeon is aware that he has to be careful when performing the uncinectomy. Another variation are these accessory ostia of the maxillary sinus. Please do not call this the true maxillary sinus ostium. The true maxillary sinus ostium always will drain into the ethmoid infundibulum. The frontal sinuses develop as an outpouching, most often from the frontal recess or less frequently from other anterior ethmoid cells. Thus, the frontal sinus can sometimes be genetically considered an ethmoid sinus. It should be noted that the frontal sinuses are absent at birth and then continue to grow to about 20 years of age. Frontal sinus drains via its ostium into the frontal recess, bordered by the vertical attachment of the middle turbinate medially, the anterior ethmoid air cells anteriorly and laterally, and then in its entirety constitutes the frontal sinus drainage pathway. Some important variants: the frontal process of the maxilla sometimes can project superiorly, and that is known as the frontal beak. The thickness of the frontal beak influences the ostium of the frontal sinus. Likewise, degree of pneumatization of the anterior ethmoid sinuses can influence the drainage pathway as well. Furthermore, like we discussed previously, it also depends on the relationship or the attachment of the uncinate process to the anterior skull base, the middle turbinate, or the lamina papyracea. Like we discussed previously, if it attaches to the middle turbinate, then to the vertical attachment of the middle turbinate, the frontal sinus will now drain directly into the infundibulum. Interfrontal sinus septal cell is seen in about 30% of the cases, thought to arise as a diverticulum from the right or the left frontal sinus or from migration of an anterior ethmoid air cell. Opening as seen here is typically into the region of the middle meatus. Sphenoid sinuses typically are absent at birth and are seen only around 3 years of life. They attain adult size by puberty. Variations: lack of pneumatization by 10 years could be considered a normal variant or might demonstrate an underlying pathology such as fibrous dysplasia like seen here. A lack of pneumatization could also mean that the superior wall of the sphenoid sinus might be relatively thick, and that can be a relative contraindication to transsphenoidal procedures that are done. As against that, extensive pneumatization thins the lateral wall of the sphenoid sinus. Repeated CSF pulsations can actually erode the lateral wall of the sphenoid sinus, resulting in spontaneous CSF rhinorrhea. It should be noted that when one evaluates a CSF rhinorrhea, if it's traumatic CSF rhinorrhea, please look at the frontal sinus, the anterior skull base carefully, but when one evaluates for spontaneous CSF rhinorrhea, the most common site is along the lateral wall of the sphenoid sinus, and that site should be evaluated more carefully. The sphenoid sinus, when we evaluate certain anatomic variants that we need to carefully consider are the intersinus septum. The posterior attachment can be in the midline or can be to the lateral wall, and if it is to the lateral wall, make sure that there is bony covering seen of the cavernous sinuses. Certain anatomical structures of significance along the walls of the sphenoid sinuses are: laterally, you have the foramen rotundum. Inferiorly, you have the Vedian canal. And superiorly and laterally are the optic canals separated by the anterior clinoid process. It should be noted that if there is significant pneumatization of the anterior clinoid process, then you could have what is a dehiscent optic nerve, like seen here or better seen here as well. Sometimes it can be so significant that you can have literally like what appears to be a floating optic nerve, though it has a bony covering, not very well seen here, but you can very well imagine that if the surgeon is going in for a transsphenoidal procedure, such as a pituitary procedure, what problems he could have if there is this particular anatomic variation, and therefore this variant always needs to be looked for whenever you evaluate such cases. The Sphenoethmoidal recess is seen along the anterior wall of the sphenoid sinus. Again, notice that it is not absolutely along the floor. It is more superiorly placed, and that tells you the important role played by the cilia. A quick way to identify it on the axial plane is that you follow the common party wall between the posterior ethmoid sinus and the sphenoid sinus. Go more medially, a defect seen there is where this sphenoethmoidal recess can be identified. The ethmoid sinuses are uniquely centrally located and most well developed in humans. It consists of 4 parts: the roof, the perpendicular plate, and the 2 lateral masses, the labyrinths, which contain the air cells. The roof is formed by the vertical lamella of the cribriform plate and the orbital process of the frontal bone or fovea ethmoidalis. Quiros described 3 types of ethmoid roof architecture depending on the height of the lateral lamella of the cribriform plate. Type 1, short vertical height about 1 to 3 millimeters. Type 2, medium vertical height 4 to 7 millimeters. And type 3, greater than 7 millimeters. Longer or greater the height, greater the risk for iatrogenic injury, and therefore the surgical relevance in determining the height of the vertical lamella of the cribriform plate. The lateral wall of the ethmoid sinuses is related to the lamina papyracia, which is more thicker anteriorly than posteriorly. We described this earlier, and that is as the middle turbinate sweeps across its attachment to the lamina papyracia, it demonstrates that particular region is known as the basal lamina, and it distinguishes the anterior ethmoid air cells from the posterior ethmoid air cells. Note that there are numerous anterior ethmoid air cells and very few posterior ethmoid air cells. There are numerous anterior ethmoid sinuses. You have the Ethmoid Bulla, Agger Nasi cell, frontal ethmoidal cells, the supraorbital ethmoid cells, the suprabullar cells, the frontal bullar cells, and the halar cells. The ethmoid bulla or the bulla ethmoidalis is the largest and the most constant ethmoid air cell and therefore is an important surgical anatomical landmark. Best imaging plane is coronal and sagittal. It is bounded by the lamina papyracea laterally, by the middle meatus and the hiatus semilunaris medially and inferiorly, and the bulla ethmoidalis opens into the middle meatus. The sinus lateralis or the retrobullar recess is bordered superiorly by the floor of the anterior cranial fossa and opens into the middle meatus. The Agger Nasi cell is the most anterior ethmoid air cell. It is seen posterior to the frontal beak, like seen here, and anterior to the frontal sinus drainage pathway, like seen here in the sagittal plane. Extensive pneumatization of the Agger Nasi cell can encroach, therefore, upon the frontal sinus drainage pathway. In addition, one has to be aware of the frontal ethmoid cells by Wormald, previously described as frontal cells by Kuhn. The classification is based on the position of the cells in relation to the Agger Nasi cell, the frontal beak, and the degree of superior extension into the ipsilateral frontal sinus, and is of 4 types. Extensive pneumatization can encroach upon the frontal ostium and the frontal recess. Type 1 to 3 frontal cells all sit atop the Agger Nasi cells and are best imaged in the sagittal and coronal planes. The type 4 cell is rare in that it lies as an isolated air cell within the anterior frontal sinus, not related to the Agger Nasi cell. Here are type 1 and type 3 frontal ethmoid cells. You can see type 1 here sitting atop the Agger Nasi cell but below the frontal beak. This is type 3 sitting atop the Agger Nasi cell and goes above the frontal beak, and therefore it is type 3. This was case 4. And the significance here is in identifying the orientation of what looks like a septation within the frontal sinus. Notice that if the septation runs parallel to the anterior wall of the sphenoid sinus, it is not an intersinus septum. It tells you that basically you're looking at a supraorbital ethmoid air cell which lies posterior to the anterior ethmoid air cell. The frontal sinus will always lie anterior and medial to the supraorbital ethmoid air cell. Again, horizontal septation paralleling the anterior wall of the frontal sinus, look for the presence of a supraorbital ethmoid air cell. If the septation were to run from the anterior wall to the posterior wall, that's an intersinus septum that is present within the frontal sinus. So look at the orientation of that particular septation, which will help you distinguish a supraorbital ethmoid air cell from a septation within the frontal sinus. The drainage pathway of both the supraorbital ethmoid air cell varies from the frontal sinus drainage pathway. The supraorbital ethmoid air cell drainage pathway lies posterior and more lateral to the frontal sinus drainage pathway, as shown by the crosshair, which lies more anterior and more medial to the supraorbital ethmoid air cell. The suprabullar and frontal bullar cells constitute the remaining frontal recess cells. These cells represent pneumatization of the anterior skull base. Best imaging plane to evaluate these: sagittal. If the air cell is seen superior to the bulla ethmoidalis, it is known as the suprabullar cell. If it extends anteriorly into the frontal sinus, it is known as the frontal Bulla cell. The posterior ethmoid air cells, I told you, can be identified as those that lie posterior to the basal lamella. Another key thing that one has to notice is that when you look at the coronal plane and you see a septation within what looks to be the sphenoid sinus paralleling the roof, then be careful. If the septation extends from the superior wall to the inferior wall, that's an intersinus septum. But if the septation looks like here, paralleling the roof of the sphenoid sinus, then you're possibly looking at a posterior ethmoid sinus that is extending into the sphenoid sinus. It will always project itself lateral and posterior to the sphenoid sinus. And this particular extension of the posterior ethmoid air cell into the sphenoid sinus is known as the Onodi cell. Another case, you have a septation seen that parallels the roof of the sphenoid sinus. This is going to be an Onodi cell that projects posterior and lateral to the sphenoid sinus. There are these sort of conical projections that are seen along the lamina papyracea. These are the anterior and posterior ethmoid canals. Look at these regions carefully whenever you're dealing with epistaxis. Moving on to the Pterygopalatine Fossa, key junctional area when you evaluate the paranasal sinuses. This is a region must to evaluate. It should be fat-filled. This is the region that lies between the posterior wall of the maxillary sinus, which is contributed by the palatine process, and posteriorly you have the pterygoid plates, and therefore this particular region is known as the Pterygopalatine Fossa. It communicates medially via the sphenopalatine foramen with the nasal cavity. Laterally, it communicates via the pterygomaxillary fissure with the infratemporal fossa. Superiorly, as can be seen here, so the best way what you do is in the coronal plane you will see the maxillary sinus, and as we stop seeing the maxillary sinus, this particular region is going to be the pterygopalatine fossa. It communicates superiorly via the inferior orbital fissure with the orbit, via the foramen rotundum with the intracranial compartment, via the Vedian canal which opens into the pterygopalatine fossa with the intracranial compartment, and finally inferiorly it will communicate via the greater and lesser palatine foramina with the hard palate, and therefore you can see there's numerous connections that it has, and therefore perineural spread infection has an easy way to extend from, let's say, the hard palate to the intracranial compartment, because it will gain access to the pterygopalatine fossa region. In the axial plane, here you see the greater and the lesser palatine foramina as it heads inferiorly into the region of the hard palate. Here is a patient. As you can see here, the greater palatine foramina are asymmetric, with the left one more prominent than the right. This is obviously abnormal. This was a case of lymphoma with spread occurring into the intracranial compartment via the greater palatine nerve. So, it brings me to the structured reporting of paranasal sinuses. It is an extensive report, but you need to mention all this because it, like I mentioned, all the anatomical variants have clinical significance. So I always start by looking at the floor of the anterior cranial fossa. I will evaluate the cribriform plate, the fovea ethmoidalis. I will look for if they're intact, if they're symmetric, the Kiros type, the nasal septum. I will go into the subdivisions of the cartilaginous nasal septum, how it influences the internal nasal valve, the bony nasal septum. Then I will turn my attention to the nasal cavity, look for the presence of any hypertrophy of the turbinate, for the presence of masses. then go into each of the individual sinuses, the frontal sinuses first. I will talk about the septations. I will look for that septation that parallels the anterior wall and will not suggest that as an intersinus septum, but suggest that as a supraorbital ethmoid air cell. Look at the frontal sinus drainage pathway, the ethmoid sinuses. I will look for the migration into the adjacent sinuses and look for such as the Haller cell, the sphenoid sinuses. I will again look at the intersinus septum. I will look for the extension of the posterior ethmoid air cell into the sphenoid sinus, the Onodi cell. Finally, turn my attention to the maxillary sinuses. Pay careful attention to the ostiomeatal unit complex, and always assess the Pterygopalatine Fossa, especially in the setting of where you're suspecting fungal sinusitis or any infection in that region, or for that matter any tumor or perineural spread. And always also pay attention to the intracranial compartment, the orbits and the neck as it gets evaluated on your images. This is another thing that you cannot ignore. You want to look at the entirety of the study itself. So I hope this has been a good overview for you guys. I thank you for your time and attention.